Good afternoon, Prof, doctors, and friends. Introduce us from Group D, and we will present the result of our group discussions. And here are our group members.
A 45-year-old man came to the general hospital with complaints of nausea, dry mouth, and pain from chewing food. The patient works as a construction worker and a heavy smoker for 10 years. In the gingival region of teeth 4-5, 4-6, it appears that the ridges form reddish ulcer, are brittle, and bleed easily. The teeth of the region are loose with poor oral hygiene. Doctors have given antibiotics and anti-inflammatory drugs, but there is no result. The patient from the case is known as a construction worker who has more time working outdoors than other normal workers. As an addition, the patient is also known to have a habit of smoking. These two factors have a great influence in causing the patient to suffer OSCC.
Cigarette smoking is the primary cause of the development of oral squamous cell carcinoma. Smoking tobacco can cause hypoxia, which causes accumulation of H1F1 alpha, and later causing the apoptosis of APAF1 and cysteine aspartate specific protease 9 cells. This can increase the level of PEGFC, causing G1 or S checkpoint cell cycle arrest.
Tobacco smoke causes several genetic alterations through the action of a range of chemicals including tobacco-specific nitrosamines. It causes DNA hypermethylation and single nucleotide polymorphism on specific genes, which is p53 gene. These carcinogens are generated through pyrolysis but are also present in some forms of SLT. Tobacco smoke itself, which contains hundreds of non-toxic and carcinogenic molecules, can induce DNA damage.
Smoking tobacco creates combustion products that enter through the oral cavity and are directed toward the respiratory tract, with harmful substances such as tobacco-specific nitrosamines and benzopyrene, along with nicotine, the addictive component, being absorbed by the lining mucosa and entering the systemic circulation. This increases carcinogen level in bloodstream.
Oral squamous cell carcinoma development itself is coexisted by poor oral hygiene. POH works as a catalyzer of carcinogenesis by increasing the carcinogenicity of some known carcinogens, such as smokeless tobacco use, smoking, and alcohol consumption. Followed by the habit of smoking, POH indicated by high dental plaque formation and bacterial biofilm. Increases the formation of N-nitroso compounds and nitrosamines. The above factors can affect the host immune response and cause the change of cells into malignant tumor cells, resulting in OSCC.
The clinical features of the OSCC in this case was cauliflower-shaped exophylic stump, easy to bleed, brittle on the gingival region of teeth 45 and 46. The treatment of the carcinoma in this location is a common surgical procedure.
In this case, the histopathological image was obtained in the form of a picture of atopic cells, mitotic cells, angiogenesis, and the formation of keratin pearls. Based on Broder's 1920 classification, this shows a moderately differentiated oral squamous cell carcinoma with 50 until 75% of cells undergoing differentiation or grade 2.
The prognosis of gingival cancer is not very good. Where in the 105 cases reported by Martin, only 26% of patients were alive and free of disease 5 years after treatment. If the lymph nodes have metastasized, the survival rate is poor. Therefore, the need for proper early diagnosis by dentists to increase patient survival.
This is the end of our group presentation. Thank you for your attention. Bye.